Ladies and gentlemen, I think there will be a few stragglers actually, but we will make a start. My name is Ian Norman, and it's my great pleasure to welcome you to King's College London on behalf of the Faculty of Nursing, Midwifery and Palliative Care, and to this special occasion, this evening's inaugural lecture. Now, the inaugural lecture series is well established within the faculty, and an inaugural lecture is always a special occasion. It's an opportunity for newly promoted or appointed professors to inform their colleagues and the university and the general public about their career so far, and to point to current and future research directions. The inaugural lecture is an important personal milestone that the new professor can celebrate with family, friends, and colleagues, old and new. And it's an opportunity for the faculty and the university to recognise and showcase the achievements of its excellent staff. Now, before I introduce this evening's inaugural lecturer, let me just tell you a little bit about the Faculty of Nursing, Midwifery and Palliative Care, which has its origins in the first professional school of nursing in the world, founded by Florence Nightingale at St Thomas's Hospital in 1860. There is another Florence Nightingale Faculty of Nursing and Midwifery. It is in Istanbul. Don't get muddled up. We are definitely the first in the world. So since Florence Nightingale established the faculty, it has gone from strength to strength. It continues to produce competent and compassionate nurses and midwives for clinical and leadership roles in the health service in the United Kingdom and across the world. And faculty staff contribute very substantially to the evidence base of professional nursing, midwifery and healthcare practice and policy through their research and scholarship. Recently, the faculty has incorporated the internationally acclaimed Cicely Saunders Institute of Palliative Care, Policy and Rehabilitation, and this will open a further chapter in the faculty's distinguished history. The faculty's success is evidenced by it being ranked as the premier faculty of nursing and midwifery in the UK and second in the world in the 2017 Shanghai World University Rankings, and number one in the UK and third in the world in the 2017 QS World University Rankings. Pennsylvania University are ahead of us, but they are in our sights. So what I would like to say is that being appointed as a professor in this faculty is quite an achievement, and it is one that we are celebrating here tonight. So it's my great pleasure to introduce you to this evening's inaugural lecturer, Professor Ruth Harris. Now, Ruth has asked me not to tell you about her biography, as she planned to do this herself in the lecture. But what I can say is that she's got a clinical background in acute medical nursing and the care of older people, and has worked in a range of research posts with responsibility for managing and leading research studies and other research capability building activities in clinical and academic settings. Ruth's research program investigates the impact of the nursing and multidisciplinary professional workforce on processes of care and patient outcomes, particularly for older people and those with chronic conditions. Aside from her research and teaching, Ruth contributes to the development of nursing and midwifery through membership of a number of prestigious bodies. She is a Fellow of the European Academy of Nursing Science, a member of the Royal College of Nursing Research Society Steering Committee, and a member of the National Institute for Health Research Trainee Coordinating Centre for Doctoral Research Fellowship Panel. And in addition, she is an associate editor of the world's best journal, the international, well, the best journal in nursing, shall we say, let's try and tone it down, the International Journal of Nursing Studies. So please join me in welcoming this evening's lecturer, Professor Ruth Harris.
Thank you very much, Ian. I actually can't see you. First of all, I'd like to thank everybody very much for coming. It's great to see so many people here, especially for people I've worked with and some friends and family, of course. What is good nursing care? How do you develop and support good nursing care? These are frequently asked questions, and we all have our views and experiences. For some of us here today, this will be based on our experience of receiving care from nurses. For others, this will be based on our professional education as a nurse and experience of delivering nursing care. And they are important questions to ask. It's not long ago that Robert Francis QC considered these questions in his inquiry into the failures in care at Mid Staffordshire NHS Foundation Trust. The report makes harrowing reading, concluding 290 recommendations, some of which are directed at nursing. Another important question to ask is, how do you know when you've got it right? How do you evaluate nursing care? Nursing is a very complex activity, focused on complex individual patient need, delivered in high-pressure, constantly changing environments. Evaluation is therefore a challenge. The purpose of an inaugural lecture is to introduce, as Ian has said, is to introduce a new professor to the academic community within a university. It's an unusual event as family and friends are also invited. And it's an opportunity to tell your story about how you've got to this point, to acknowledge the people and events that have shaped your career and what has influenced your thinking and research programme. And of course, to thank the people that have supported you on your journey. Well, at least that's my take on it. So in this lecture, I plan to tell you about my personal career journey as a clinical nurse, as a ward manager, as a researcher, as a research leader. I will also talk about 3 research studies that I've undertaken and how these studies have influenced my thinking about evaluating complex nursing interventions. Some of you may be thinking, well, isn't this your second professor post? Why are you doing your inaugural now? Well, I had an action-packed 3.5 years at Kingston University and St George's University of London and was incredibly well supported. But for a number of reasons, the lecture just wasn't arranged. However, it seems right that I give this lecture here at King's. I'm a King's graduate. I did a BSc in nursing, an MSc in nursing, and a PhD in nursing, all at King's. So although this is my story, it is also, along with all King's graduates, part of King's story. So as an alumnus of King's College, I feel very honoured to be standing here as a professor. So here I am in the first year of my education journey. I'm 5, clearly very nervous, very much like today. Not a great haircut, but I did tie that tie myself. One of the many skills my dad taught me. Thanks, Dad. A dodgy year in middle school caused a bit of anxiety. Not for me. I was having a great time. The teacher was experimenting with how the class was organised and decided to sit boys and girls next to each other. I was moved to sit with my next door neighbour, who was one of my best friends, and we happily chatted through the whole year. When my grades nosedived, my mum and dad had to intervene, particularly my mum, who's a teacher. So it's right that I thank them at the onset of this lecture, because who knows what might have happened without their support with this, and of course other things. I don't remember exactly when I decided that I wanted to be a nurse. I have 2 aunties who are nurses, Auntie Julie and Auntie Anne, and so it was always on my radar as a possible career. And then more and more I realised that this was what I wanted to do. At the time I was applying to do nursing, most nurse training took place in hospital schools of nursing. and there are only a small number of universities offering a nursing degree. But I also knew that I wanted to go to university. However, having been told that it was a very competitive process, I applied to as many universities and London hospitals as I could. In the end, I had 16 offers of places. Only St Thomas's Hospital turned me down because they thought I should do a degree. I chose Chelsea College, and it turned out to be a very good decision. 25 of us started in our first year. In the third year, Chelsea College merged with King's College. And it was a remarkable time, those 4 years. The course was 4 years with a considerable theoretical element and a stress on practical nursing skills taught by experts in the field. Their published books were our course material. And of course, it was also great that the college was on the King's Road, one of the trendiest roads in London. So here are some of the academic staff who taught us. You may recognise quite a few of them. People I'd like to point out are Sally Redfern. She had an amazing influence on me in my career, throughout my career. Lynn Bateup, some of you might see her. If you can't see exactly who it is, let me know afterwards. I can tell you who everybody is. I daren't use the pointer because of my shaking hands. Fiona Ross is there right at the back in the centre. And of course, Jennifer Wilson Barnett, right at the front in the centre, who is here today. And those people were incredibly supportive and have had an enormous impact on my career. 19 of us completed the course. Here we are. And we were awarded a BSc in nursing by King's College. And this photo was taken at a celebration event in Chelsea. Lisbeth Hockey, one of the UK's first pioneering nursing academics, gave us an inspirational talk about how we could influence nursing. And I'm kneeling on the ground second from the right. And I've realised in preparing this lecture that we graduated 30 years ago this year. Frightening. My first job on graduating was on a medical ward at St James's Hospital in Balham. And it was as part of a 1-year staff nurse development programme. I wasn't there when this photo was taken, but it was the only one I could find on the internet. I remember my first day. I was on a late shift. I was very nervous and I was very excited. And it turned out that I was the only member of qualified staff on that shift, which was quite a shock. A bigger shock was that there were 4 qualified members of staff on the early shift, including 2 sisters. Not every shift was like that, but it was very challenging at times. However, I stayed the full year. So how did my nursing degree prepare me for clinical practice? I was very idealistic. I had very high expectations of myself to deliver patient-centred, evidence-based nursing care. I felt quite angry at times with myself, with the ward, with King's, that it was not possible to deliver what I thought I should be able to deliver. I remember one patient had been prescribed a Usol and paraffin wound dressing. Usol is a bleach-like substance which damages the skin, so being concerned, I did a literature search about the effects of Usol, and I gave my findings to the senior houseman who had prescribed it. Most of the academic papers were for medical journals. One surgical paper in particular demonstrated that Usol irreversibly damaged the microcirculation in a rabbit's ear, and it wasn't unusual to do research, wound care research on animals for these sorts of studies. So when I asked the senior houseman a day or so later what he thought of the papers that I'd given him, he'd said, "Well, this is really useful, Ruth. Thank you so much. Next time I'm treating a rabbit with a pressure sore in its ear, I promise you I won't use Usol." And of course, the prescription didn't change. After that year, I moved to intensive care at St George's Hospital. It was quite scary at times. I was there at the time of the Clapham train crash in 1988. I learned such a lot about physiological systems and supporting families. And I loved having one patient and one family to care for on a shift. After almost a year, I saw a job advert for an F-grade primary nurse post. An F-grade is now a band 6 post. And it was on a general medical ward at Dulwich Hospital, which is part of King's College Hospital. And I jumped at it. But why would I do that? Why consider leaving the high-tech, one-to-one nursing environment for another medical ward, and a medical ward in an old Victorian hospital building? Well, the ward was being developed as a clinical nursing research and practice development unit led by Lynn Bateup, who was on the photo of the King's College staff. And Lynn was supported by the then chief nurse, Mary Godfrey, and of course Jennifer Wilson-Barnett here at King's. Here's a photo of the ward. As you can see, it's just a normal, in the background, it's just a normal standard Nightingale ward. There wasn't anything special about it. I'm on the left, by the way. The ward had started using a system called primary nursing to organise the delivery of nursing care, and the main role of the primary nurse was to accept responsibility and accountability for the nursing management of a specified caseload of patients, from their admission to discharge, and to lead a team of associate nurses to provide continuous care for this caseload. Being able to work in this way and to contribute to the development and evaluation of nursing practice fitted my ideals perfectly. Shortly after I started, the ward was successful in our application to be a King's Fund-funded nursing development unit, one of 4 units nationally. Here is part of my job description as a primary nurse, so you can see why it was my dream job. The ethos was to improve the quality of patient care through the development of nurses and nursing. On Byron Ward, our focus of development was through the development of primary nursing, patient participation in care, and individual performance review for nurses. This was an environment where being idealistic was valued and supported. There were still challenges, of course. Here is another example of my efforts to influence my medical colleagues. I can't remember writing this letter, but I found it in papers I kept about the nursing development unit, thinking that they would be important one day. And I cringe when I read it. But as you can see, I describe the patient as my patient, and I sort of backed the doctor into a corner. I don't remember what happened. Probably best not, really. But it does show that I took my accountability very, very seriously. The nursing development unit was a very research-intensive environment for staff, not only using research evidence in planning care for patients, but also as subjects of research ourselves. The Department of Health provided funding to evaluate the 4 King's Fund nursing development units, and Lynn Bateup was also conducting an action research study about primary nursing. So we were frequently observed and often asked to complete questionnaires. We also conducted small studies ourselves, for example, to evaluate patient, family and staff views about nurses not wearing uniforms. The reason this came about was because the primary nurses had been wearing staff nurse uniforms. And we thought that this had undermined our efforts to lead patient care for our caseloads. Everyone wanted to talk to Amanda Evans, the ward sister. And the medical consultants weren't happy if she didn't go on ward rounds, even though they were our patients and we knew them better. So we were given 2 alternatives. We could either wear Navy sisters' uniforms or wear our own clothes. So we chose the latter, as we thought patients would feel less comfortable with us if we wore some more senior uniforms. But we were told we had to evaluate it. So after 3 months, we asked patients, family members and staff to complete questionnaires. We found that patients either liked it or really weren't bothered what we were wearing. Patients' families liked whatever the patients liked, and the doctors were less keen. But the nurses liked it. We felt more human somehow, and people remembered our names, so we kept it. In the photo, you can see I'm in the middle, and some of you may recognise Peter Griffiths, a researcher, professor in Southampton, at the back. The patient's name was Rose. I was her primary nurse, and I learnt so much from working with her. After 3 years, the survival of the nursing development unit was threatened by an internal reorganisation at King's Healthcare, and this coincided with the Audit Commission's Lying in Wait report in 1992, which showed that 48% of patients occupying acute medical beds did not need acute medical services, although most of these did need inpatient care, just not acute medical care. So the unit's response was to propose the development of a nursing-led inpatient unit on Byron Ward. So what's a nursing-led inpatient unit? Well, it's a unit that provided inpatient beds for people who primarily needed nursing care. For example, patients who required further rehabilitation after stroke or after hip fracture, or who had complex wound management problems. The beds were managed by nurses who decided which patients were admitted and when they were ready to be discharged. The premise was that on acute wards, the needs of patients who were medically unwell and unstable would need to be prioritised by nurses. And so by transferring patients who had similar subacute nursing needs to the nursing-led inpatient unit, they would not be competing with sick patients for nurses' time. At that time, there had been 3 nursing-led inpatient units that we were aware of. The Loeb Centre for Nursing at the Montefiore Hospital in the Bronx in America, led by Lydia Hall, the Burford Nursing Development Unit and the Oxford Nursing Development Unit, both led by Alan Pearson in the UK. And we built on this work and expanded it further. I became the ward manager and senior primary nurse for this new nursing-led inpatient unit. So what was it like to work in this innovative ward? Earlier, I recalled 2 of my admittedly somewhat clumsy strategies of trying to influence medical colleagues about prescribing appropriate wound care treatments for my patients. And on the nurse-led unit, I didn't need to do this. I could make that decision myself. It was exhilarating, it was creative, it was collaborative. We built a really strong team. We took initiative and responsibility, and it made me feel very proud of what we were able to do. One of the primary nurses, Jonathan Williams, who unfortunately can't be here today, described it as the opportunity to be maxi nurses, not mini doctors. However, it came with additional stress. We had to be really very good at patient assessment and clinical decision making, and problem solving was very important. We had regular case reviews, and we could support each other to find solutions to difficult situations. As a ward manager, I did have some sleepless nights. Naturally, I think. We were one of very few units in the country, if not the only one when we first started, and it felt a big responsibility to me. To patients firstly, of course, but also staff, ensuring that I supported them adequately and facilitated their professional development to undertake this innovative role. As a nursing profession, and of course to the nursing profession as a whole, as you can see from my slide, we were in the nursing press quite a lot. And even the Daily Mail. And the Guardian, actually, but it wasn't such a good headline. It was very important to evaluate the way we were working, and a research study was conducted, led by Peter Griffiths, who had been appointed as the Nursing Development Unit researcher, and in collaboration with Jennifer Barnett here at King's. After 5.5 years on Byron Ward, I moved to a research role. I was finishing a part-time master's degree in nursing here at King's. Jenny was my supervisor. And so the timing was right for me to move to a research role. And my first job was an evaluation for a stroke unit for older people led by Professor Lalit Kaura, a stroke physician. And this study resulted in a continued funding for the unit. And then another perfect job came along. I was appointed as the lead researcher for a study to evaluate a nursing-led inpatient unit that had opened at the Homerton Hospital. In this photo, I'm second from the left. The staff in the Homerton Hospital had visited and sought advice from Byron Ward to develop their unit, and this evaluation that was funded by NHS Executive North Thames was in collaboration with Jenny and Peter at King's. I registered to do a PhD, of course, at King's. No surprise who my supervisors were. And this is the first of the 3 studies that I want to tell you about. I've already told you that patients were transferred from care from a medical consultant to a primary nurse for the remainder of their hospital stay in a nursing-led inpatient unit. And this you might think was unusual and might appear risky. And so it was really important to find out whether patients were safe, whether they were discharged quicker or longer, whether they were more independent when they were discharged, and of course what the service cost. The study was a randomised controlled trial comparing the outcomes of care for patients transferred to the nursing-led inpatient unit and the remainder of their hospital stay managed by a primary nurse compared to patients who remained in the medically led wards managed by a medical consultant. The study replicated the 2 previous evaluations of Byron Ward with, of course, some improvements. So essentially the question I asked in my PhD was an effectiveness question. Does this nurse-led inpatient unit intervention work or not? The main findings of the study were that there was no significant difference in patient clinical outcomes. For example, functional independence, general well-being, place of discharge, mortality, readmission rates, incidence of pressure sores and incidence of falls, and patient satisfaction of care. There was a pattern of improvement, but nothing was statistically significant, which was disappointing. However, length of stay on the unit was significantly longer, a lot longer. And so although cost of care per day was cheaper on the nurse-led inpatient unit, cost per stay was significantly higher. So the study demonstrated that nurses could safely manage inpatient care for patients who had subacute needs, and in that respect, the nursing-led inpatient unit was as effective as usual medically led care, but at a considerably higher cost. So why was this? Did the nursing-led model of care not work? Well, we couldn't say. And although my study included more detailed data about nursing activity, estimates of the level of medical and multidisciplinary input, and an assessment about how nursing was organised, these data were descriptive, and their use in explaining the unexpected findings was limited. For example, was length of stay longer in the nursing-led inpatient unit because nurses were less used to taking responsibility for discharging patients? So kept patients just a little bit longer to make sure that everything was okay? Or the nurses were maybe focused more on rehabilitation? Well, we couldn't say, because we had investigated what had happened, not why did that happen. We could make educated guesses about the reasons why there was no difference in patient outcome and why length of stay was higher, but we couldn't explain it with confidence. We didn't ask patients about what care they had received or observe patient care. We didn't talk to nurses about how they managed their caseloads. We didn't ask nurses and doctors how they made decisions about when a patient was ready to be discharged, for example. So in the conclusion of my PhD study, I recommended that in future work, research approaches should be used that address the complexity of an intervention and variation with which it is delivered, thus building our understanding of how an intervention works, the conditions that promote or inhibit this, and the impact on subsequent outcome. I also briefly mention a research approach called Realist Evaluation, which was developed by Ray Corson and Nick Tilley. Little did I know that this would be a method that I would use in future studies. As the Homerton evaluation was completing, I was keen to continue to work in the NHS. And another dream job, I have lots of dream jobs, another dream job for me was advertised, and it was for a senior nurse for nursing research and development at Northwick Park Hospital, to develop a real and lasting culture among nurses that is supportive of scientific inquiry and committed to the implementation of evidence-based practice. The reason it was my dream job was because Richard McMahon was the director of nursing, and he would be my boss. And Richard was one of the primary nurses on the Burford Nursing Development Unit. And I had read and reread his books on therapeutic nursing. Oops. Looking back at the report I wrote after the first year, I had made considerable progress to begin developing a research culture in nursing. However, after that first year of my 2-year contract, Richard left Northwick Park and the funding for the post was not renewed by his successor. And during my time at Northwick Park, I worked on a study, you can see the paper here, exploring the impact of these lead research and development nursing roles. And it's very ironic that 4 of the authors of this paper held a lead research and development post when we started this research, but only one of us had their fixed-term funding renewed when we published the paper. This contributed 2 very important learning points for me. The support of the executive leader is paramount to innovation, and funding for nursing research development was wholly inadequate, and I would argue still is. Thankfully, there is some funding for clinical academic careers for nurses today, but it was non-existent then. But Jenny came to my rescue, and I applied and was appointed as a full-time research fellow at King's, working on a range of projects with a clinical evaluation research group led by Jenny. I finished writing my PhD, and when I tell you that I finished my PhD during the first year of married life, you will realise just how supportive my husband Keith is. I joined the National Nursing Research Unit here in King's in 2004, which was led by Professor Fiona Ross. who is also in that picture right at the beginning of the department at King's. The National Nursing Research Unit was funded by the Department of Health Policy Research Programme to develop a programme of research addressing priorities in nursing. And I became the Deputy Director and contributed to the quinquennial review, which was successful, resulting in a further 5 years of funding. As it turns out, this was the last round of funding the unit was awarded. When Fiona left the unit, I became the acting director for 7 months. This is the photo taken at the 35th anniversary of the Nursingled, the Nursing Research Unit, and you can see Fiona on the left, then Jack Hayward, Jill Mavens next, Peter Griffiths, and myself at the end. Sally Redfern isn't in this photo, but I felt very honoured to have been included in this group. Someone once gave me some brilliant advice, career advice. When you find a great boss, stick with them. And it certainly worked for me over the years. So after I had managed the process of the appointment of the new director of the Nursing Research Unit, I moved to the multi-professional Faculty of Health and Social Care at Kingston University and St George's University of London as a senior researcher to continue working with Fiona, who was and had been a fantastic mentor. And it was shortly after starting at Kingston and St George's that I was awarded my first research grant as a principal investigator. And this is the second of the 3 studies I want to tell you about. The National Institute for Health Research have put out a tender for studies on interprofessional team working. And I was really keen to apply, but I hadn't been invited to join any existing bids, so I decided that I had to lead an application and put a team together myself. And it was a great team. We had amazing researchers, Sarah Sims, who's here today, who works with me still at King's, and also Gillian Hewitt. And there's also Vari Drennan is here today, as is Sally Brearley. Lalit Kaura, who I'd worked with years before, I remember nervously emailing him. He was now Professor of Stroke Medicine at King's, saying, "You may not remember me. I worked with you 14 years ago, but I'd really like to invite you to work with us on this study." And I felt so hesitant to press that send button, but then thought, well, what's the worst that can happen? And as it turned out, the best happened. He replied within 15 minutes saying, "Of course I remember you and I'd be delighted." So why were we so keen to do research about interprofessional team working? In healthcare and life generally, of course, teams are everywhere. There's the nursing team, the medical team, the physio team, the infection control team, the catering team, the management team. And teams are getting more complex as they include both health and social care practitioners. So what is it about teamwork that works? Well, surprisingly, while there was an extensive literature to guide professionals and managers of methods and types of team working, little is known about the impact of team working on patients and their outcomes and experiences of care. We decided to do the study in stroke for several reasons. Stroke is very prevalent in the UK. In the UK, around 1 person has a stroke every 5 minutes. There is evidence that people who receive care in stroke units with an interprofessional specialist team, comprising, for example, of medical staff, nursing staff, therapists, dietitians, psychologists, are more likely to be alive at home 1 year after their stroke. And so it was an ideal area to address the funder's commissioning brief to examine which characteristics of an interprofessional team have an impact on the effectiveness of teams. So we conducted a multi-method study drawing on Realist Evaluation approach developed by Ray Pawson and Nick Tilley in their seminal work. Realist Evaluation is a theory-driven approach designed for evaluating complex social interventions. It does not seek to answer the question, does this intervention work? But instead acknowledges that complex social interventions only ever work for certain people in particular circumstances. The key task of a realist evaluation is to understand and explain these patterns of success and failure by asking the exploratory question, what is it about this intervention that works, for whom and in what circumstances? And we saw interprofessional teamwork as a complex social intervention, whether outcomes are influenced by the way the team works together and the context within which the team works. Therefore, an interprofessional team may work very well in one stroke unit, but not in another. We collected data using lots of different methods. For example, we conducted in-depth interviews with patients, carers and staff. We assessed patient outcome data from hospital stroke registers. We observed interprofessional team meetings. We asked staff to complete team performance and work-related quality of life scales. An important part of the realist evaluation occurs at the beginning of a study, when you identify what are the underlying assumptions of why you think an intervention will work. These are called program theories or mechanisms. So the research team spent a lot of time reviewing the extensive team working literature and thinking about what it was about the interprofessional teams that might influence how the interprofessional team works. And we came up with 13 mechanisms or preliminary theories. Each theory had a detailed description. So for example, we described leadership as teams have a clearly identified leader who sets the tone and culture of the team. The leader engages and motivates the team, ensures that communication is free-flowing, and ensures that all members are able to participate in the team and feel supported. Through this, they elicit commitment to the team and its objectives. The leader creates a safe climate for constructive disagreement and ensures conflicts are resolved. They provide feedback on team performance and encourage reflection, openness, and a learning culture. The leader does not necessarily have to be responsible for the team's administration and housekeeping. And we had a description like that for each one of those mechanisms. These mechanisms provided the theoretical framework of how we analysed our data. We were looking for evidence that either supported or refuted our preliminary theories, and seeing the context or conditions that facilitated or inhibited those mechanisms, and then the outcomes that resulted from this. We built up patterns of what works for who and in what circumstances. It sounds very complicated, because it is, and we struggled to get our heads around this approach, and we know many researchers who also struggle with it, but I think it's worth it. Our findings did explain some of the variation about what works for whom and in what circumstances. I can't go through all the findings, but some of the key ones are as follows. So what works for patients? Well, an important finding of the study was that teamwork is largely invisible to patients and members of their family. They struggle to talk about it, even when we ask them direct questions. This doesn't mean that the effects of teamwork are not important to them or they don't benefit from it, but it does suggest that they look beyond the processes of how care is delivered and focus on aspects of care that are important to them. Here, one carer describes this perfectly. It's like if your car works really well and never goes wrong, you don't open up the bonnet to see why the engine's working so well, do you? You're not curious, you take it for granted and are very pleased that it does. So what aspects of care are important to patients and their family carers? Well, they valued communication with team members, and when this met their needs, they were reassured and they felt safe and they had confidence in the team. They liked to see collaboration between professionals in joint sessions, and here's another quote from a patient who valued that. The physiotherapist and the OT spoke to each other about what they were going to do, and they sort of demonstrated to each other with me, which was brilliant, really. They also valued coordination between professionals and services, and when this worked well, it gave patients and carers confidence in the team. And here's another carer saying, I think he's realised actually that if I say something to one person here, the whole team is becoming involved and aware about it, so I think he feels more secure because of that. And what worked well for staff? Not surprisingly, interprofessional team working was considerably more important and visible for staff, although some aspects worked better for some teams and team members than others. So firstly, what works? Clear leadership. We found clear leadership was highly predictive of how teams rated their overall performance. Regular meetings and co-location facilitated communication, coordination and collaboration. Joint sessions between clinicians of different professional groups was thought to improve care quality and efficiency, although almost always this occurred between therapy staff. There was a statistically significant association between team performance and staff work-related quality of life, demonstrating that when the team was working well, staff had higher morale and higher job satisfaction. And what does not work well for staff? Firstly, a large team. Several of the teams we studied were very large, around 80 or so members who were working directly with patients in a clinical capacity, and this had a number of detrimental effects. Including staff feeling too intimidated to contribute, team leaders being less available to team members not knowing each other very well. Some team members that we worked with didn't know each other's names, and some team members were not included in all the team meetings. So here's a physiotherapist saying, sometimes there can be dominance from one particular person whose opinions will take over, and if you're not necessarily confident to challenge that, it can be quite intimidating to turn around with opinion to say, actually, I'm not sure I agree with that. Another thing that doesn't work well was conflict in team leadership. Where there was conflict in leadership, team performance was less effective. Where there was ambiguity in team leadership, so although having one clear leader was beneficial, team members received most of their support and their guidance from their uni-professional leaders. So for example, a speech therapist would go to a leader in speech therapy, and this caused ambiguity in leadership. Most staff members considered themselves as members of at least 2 teams, and that's complicated. So for this, here's a speech therapist saying, I think the whole place does suffer from the fact that there is no one really in charge. There is no sort of centralised lead for the place. Another thing we found that didn't work was uni-professional activity targets, where team members had their own activity targets. So where they had these targets, they prioritised these, diverting their effort away from interprofessional activities, which undermined the way the interprofessional team worked. And here's again another speech therapist saying, because the message coming through all the time is, these are your targets, this is how many people we need to see, this is what you have to do. And finally, what a hierarchy between individuals and professionals did not work well for the team. When staff were not valued or were treated with disrespect, they withdrew from the interprofessional team and did not collaborate with other professionals. So here's a healthcare assistant saying, if you told me to make a pyramid, it would be the doctors and the consultants on top, with the consultants at the peak, therapists in the middle, ward manager, then towards the end the nurse, and then at the end of the barrel the healthcare assistants. We found using a realist evaluation approach really useful in helping to understand the variation and complexity in how interprofessional teams work and evaluate what works for a range of stakeholders. The theoretical framework we developed for the study was published in the Journal of Interprofessional Care. The editor, Professor Scott Reeves, who is here today, was really supportive about the challenge we were experiencing writing up such a complex synthesis of literature in one academic paper. And he generously allowed us to submit a series of 4 papers. And these papers were recently awarded the journal's annual Baldwin Award on the basis that they significantly contribute to the evidence base informing interprofessional education and practice worldwide. Our findings from this study contributed to the funding application of another study, which is funded by the National Institute for Health Research and is led by Professor Fiona Jones at Kingston University and St George's and David Clark at the University of Leeds, to explore the strategies to increase levels of patient therapeutic activity in stroke care. And I'm a co-applicant for this study, along with colleagues at King's, Professors Glenn Robert and Chris McKevitt. We completed the team study during the 9 years I was at Kingston University and St George's. I received fantastic support from Fiona Ross as Dean and also Vari Drennan, who's here today, as the Associate Dean for Research. I was promoted to a reader and then appointed as Professor of Nursing Practice and Innovation. And then, following the last Research Excellence Framework, I began to think about working in a more intensive nursing research environment. In my performance review, Vari had challenged me to think about what I wanted to have achieved before I retire and to make plans to achieve that. And then I saw the advert for King's, and here I am. The grant for the third study I want to tell you about was awarded while I was at Kingston and St George's and then transferred to King's with me. The study is funded by the National Institute of Health Research as part of a call for studies to evaluate interventions to address the recommendations from the Francis Inquiry. One particular recommendation prompted the implementation of intentional rounding. And that recommendation was that regular interaction and engagement between nurses and patients and those close to them should be systematised through regular ward rounds. And intentional rounding is a structured process whereby nurses in hospitals carry out regular checks, usually hourly, with individual patients using a standardised protocol to address issues of positioning, pain, personal needs, and placement of items, or as they're commonly known, the 4 Ps. And here's an example.
Good morning, Keith. My name's Estelle. I'm the ward manager and I'm looking after you today for the early shift.
Thank you, yes.
How is your pain today?
I'm very comfortable, thank you.
That's very good. Would you like me to assist you to go to the bathroom at this time?
I'm okay, no.
Okay.
Right.
Are you comfortable?
I'm very, very comfortable.
Would you like a change of position?
No, I'm comfortable, very comfortable.
Okay. And you've got all your drink to hand, your nurse call bell. Would you like me to put your wash bag away in the locker for you?
Yes, please.
Is there anything else I can help you with,
No,
Keith?
Quite all right, thank you very much.
Okay, I will be around within the next hour.
Yes.
If you need anything, please use your nurse call bell, don't
Right,
hesitate.
okay, thank you.
All right.
Yep.
So our study to evaluate intentional rounding uses a multi-method study design to evaluate the impact and effectiveness of intentional rounding in English hospital wards on the organisation, delivery and experience of care from the perspective of patients, their family members and staff. We're using a realist evaluation approach again. We did consider using a randomised experimental study to assess the effectiveness of this intervention. However, the use of this approach is not possible as the implementation of intentional rounding has been strongly advocated and promoted by the then Prime Minister David Cameron, and very few trusts are reported not to have implemented it. We have conducted a realist synthesis of the international literature, and we've conducted a national survey of directors of nursing in all acute NHS trusts in England, and have conducted in-depth case studies with acute wards and care of older people wards in 3 acute NHS trusts, purposefully selected from the survey data, so that's 6 wards in total. And to date we have interviewed patients, family carers, nurses and other healthcare staff and managers, around 140 interviews, and we have conducted approximately 150 hours of observation of direct nursing care delivery. We have now completed data collection and our data analysis is in progress, and as you can see we have an awful lot of data. Unfortunately I can't tell you about the study findings today, but I can tell you a bit about the realist synthesis of the existing international literature that we completed in the first phase of the study. We identified 8 preliminary programme theories or mechanisms of why intentional rounding would have an impact on patient care delivery. And we identified these from the policy literature, the grey literature and research literature, and a stakeholder consultation event. In a similar way to the teamwork study, we are testing these preliminary programme theories or assumptions about why intentional rounding is thought to work throughout the study. For the realist synthesis, we have reviewed the international empirical literature. We've looked at 44 papers, the majority in the professional press, 18 in peer-reviewed journals, the majority coming from the US and then the UK. The evidence is methodologically weak, so drawing conclusions is limited. However, it has raised some interesting questions. For example, our detailed description of the consistency and comprehensiveness mechanism is this. Intentional rounding helps keep patient care consistent through the use of a structured, systematic approach, ensuring all patients' needs are met and potentially less obvious aspects of care are considered and managed at every round. This consistency of care gives confidence to patients, their family members and staff, and it can also prompt agency nurses to deliver care to a required standard. Intentional rounding also helps ensure that family members are provided with consistent care and information in line with their needs. In the literature, we did find some evidence for this mechanism of intentional rounding. The context that enables this is when staff think intentional rounding is a good idea and when they are clear why they are doing it. Typically, it works well for quieter patients who need more help, and it can provide reassurance to patients, their family members, and can lead to higher patient satisfaction, reduced call bell use, reduction in patient falls, and a reduction in pressure sores. However, as I said, the outcome data in particular is methodologically weak. However, there is much more evidence in the literature that rounds are not consistently carried out by all nurses or for all patients, or that nurses are not conducting the intentional round according to the recommended protocol. Nurses were seen to use clinical judgment and professional autonomy to modify the rounding process, assessing patients on an individual basis and making informed choices about how frequently to conduct the rounds and what questions to ask. Where there is a lack of staff, nurses were more likely to adopt the protocol. Where patients were more self-caring, staff may feel silly asking the 4P questions. Or where there is a lack of clarity about intentional rounding was meant to achieve. Another preliminary theory is accountability. And here is the assumption that nurses being required to complete and sign the intentional rounding record to say that they have carried out the hourly checks will feel more personally accountable for the standard of care, which will then lead to higher standards of care and provides a protection for both patients and staff, as staff can evidence what they have done. However, in the literature, we found that accountability for rounding seemed to focus more upon the completion of the intentional round documentation rather than on the ability to carry out a high-quality care within an intentional round. And there was no evidence that increased personal accountability led to the delivery of higher standards of care. So intentional rounding may be more of a means of offering assurance to key stakeholders, for example, patients, relatives, nurses and managers, about the care being delivered. So undertaking a realist evaluation has been a really useful step, not just to generate the theoretical framework to guide the study, but also to understand the international context of how and why the intervention has been implemented. For example, in the United States, intentional rounding seems to be linked more to customer satisfaction, whereas in the UK it appears to be driven more by risk management. And this is something that we are very keen to investigate further. So these three studies show how my work and thinking about evaluating complex interventions is developing, and it's certainly an ongoing process. At the beginning of this lecture, I asked the question, how do you evaluate nursing interventions? And my answer would be that you need to take into account what a complex activity nursing is and design the evaluation that takes into account that complexity, looking for variation and the reasons for variation. In trying to do this, we have found realist methods very challenging, but very useful. We still ask this question. We've been doing this for 9 years, and sometimes still in meetings, one of us will say, usually me actually, can you just remind me what a mechanism is again? So I don't use, I've told you about 3 studies, I don't use realist evaluation all the time, but it is the most challenging approach that I've used, and that's why I've presented this today. But I do want to emphasise that other research methods are available. Last year at a conference presentation, Ray Pawson talked about his ideas around how to progressively build on our understanding of complex social interventions. Different social programs or interventions often use the same mechanisms of action, which offer great potential in evaluation. And he talked about the possibility of mechanism libraries, where the understanding of the potentialities and the liabilities of program mechanisms could be brought together in some way. And I think this sounds a really interesting way of building our knowledge of what works in nursing. When I look back at the nursing-led inpatient unit and think about what mechanisms or theories we might have identified for how this intervention worked, I think we might have identified accountability of the primary nurse for a caseload. We might have identified visibility of the primary nurse who provided care for their caseload on every shift they worked. We might have identified allocated time to care. As a ward manager, I saw my job to protect the primary nurse from admin tasks that took them away from their patients. So I think that there is scope to develop transferable knowledge so that we can develop cumulative understanding of the effectiveness of complex social interventions and building knowledge across healthcare and nursing. So this leads me to tell you a bit about some of the future work that I'm hoping to do. And of course I have to say we'll complete the intentional rounding study, and actually we had a meeting today, and the data is really exciting. And we're really keen to expand the research with international collaboration so that we can learn more about how the intervention works by looking at it in different international contexts. I'm really excited to be working alongside the CREATE study, which is a really exciting study working with service users to increase therapeutic activity in stroke. And as you can see, I think ward managers are the staff with the most influence in patient care. So I'm delighted to be working with Jackie McKenna at NHS Improvement on her postdoctoral work. And we've submitted a funding bid with Liz West and really hope to continue to work in this area. I'm also developing grant proposals with Scott Reeves in the area of leadership of complex teams, and this is a really exciting development. And I'm also here at King's working with the team on the Older Person Nursing Fellowship and associated projects, which is really, really exciting, focusing on developing care for older people by developing and supporting junior and senior nurses. And this to me is akin to the King's Fund ethos of nursing development units, and it's just a fantastic programme. As I draw to a close, I want to thank you again for coming this evening. I really appreciate your support. Thank you to everyone I've worked with, the patients, the carers, the clinicians, the academics. All the work I've talked about would not be possible without these great teams. I have specifically mentioned some people during my lecture, but there are so many more, far too many to specifically mention, but all have been so important. In her work, one of my colleagues, Professor Jill Mabon, who's also here today, identified 3 groups of nurses: crushed idealists, compromised idealists, and sustained idealists. So returning to the title of my lecture, From Idealism to Realism, and having taken this opportunity to look back on my career, I can honestly say that I'm a sustained idealist. My education at King's gave me the ideals to work towards, and I have been sustained and propped up at times by the fantastic people I've worked with and my wonderful family and friends. Thank you.
Thank you very much, Ruth. Now, by tradition, there are no questions at an inaugural lecture, but I would like to introduce somebody who got more than one mention, in fact, in Ruth's lecture, Professor Dame Jennifer Wilson Barnett, who's a former dean of this faculty and was Ruth's PhD supervisor, who is going to give the vote of thanks.
Well, thank you very much, Ruth. Now, if I speak from here, can everybody hear? Okay, because it's really nice to see you all. So, Ruth, well done, congratulations, fantastic. It is so wonderful to be able to say, Professor Ruth Harris, well done. And it's so wonderful that another King's graduate times 3, 2, is up at the absolute dizzy heights of a chair at King's. So, well done, thank you. I think it's really quite amazing. It must be a bit of an anathema for Ruth actually to give an inaugural lecture, because my impression of her was that she was very quiet and self-effacing and would work very, very quietly on her own studies. Admittedly, in the ward situation, she was out there and omnipresent. But I remember from the PhD studies, it was quite obvious that really we had to make appointments in order to see her. And very often she would postpone and take a little longer than we would have liked. But when the chapters came, they were absolutely excellent. So the lesson of that story is you have to wait for excellence. But it was a delight. I didn't really supervise Peter Griffiths, and I had a jolly time with the study, which was a great achievement. And what's really nice is that, I think so many PhDs are really excellent nursing research, actually. When you read them, they're fantastic, and it's so wonderful that you have the opportunity and you can build on a PhD in your career in research. I mean, that's an absolutely excellent model to try and achieve. But Ruth, so much of what you said is so good. And I think that, okay, so you are a private person. The little evidence I have is that I didn't know of this wonderful, wonderful romance that was going on during the PhD until I had this wonderful invitation to the wedding. So that's, I'm sure Pete will adhere to that, but everything obviously went on quietly behind the scenes. But that was so delightful, and it was here, of course, at King's, the actual wedding reception, which was really lovely. So I won't go on too much about the studies, except the ones I actually know about. The nurse-led units were phenomenal, but a couple of things to stress that perhaps Ruth doesn't so much think are so important was that it was a randomised controlled trial for the nurse-led unit. And if you think about how difficult that would be in the context of an acute hospital to randomise patients to either or. And it was because of the partnership with the managers and the researchers that this was achieved. And I think this lesson goes, if you really can work well with particularly nurse managers, a lot can be achieved. And the nursing prowess and the excellence of all the staff on the nurse-led units, I mean, they really were excellent people. And I think the phenomenon of being able to collect all that data and to analyse it, and not only that, but Peter is such a whiz with statistics, and we were really overwhelmed by how well you did in terms of all that analysis. So fantastic. I was really very impressed. The other thing it demonstrated really to me was that non-surgical patients past the acute time come into hospital for nursing and therapy care. The reason they're in hospital, medical wards, other non-surgical, is actually because they need intense nursing. And this really was demonstrated in the nurse-led unit to me, that the contribution of nurses was extremely good. It took a little longer, obviously, to get them to actually acknowledge that the patients could go home without them. But it was wonderful. The other thing about the stroke unit in particular for me was that we have done some more stroke work, and the contribution after the acute period of physiotherapists, OT, and particularly nurses with positioning is absolutely vital. And I'm not surprised you looked at teamwork, because where it really worked was in, again, the non-acute phase, where nurses in particular were absolutely stringent in their positioning of patients. And Joan's work showed very clearly that you could prevent severe contractures of the affected arm with really good, intense nursing as a rehab. So that was great. I'm sorry about all the muddle of teamwork and all the sort of problems with that, but I know that you like to look for problems, and it's okay, but we like to look at the positive outcomes, really. But it was a very good idea to look at everything else that was going on. The last study, I think, is quite fascinating, because I did actually read the little piece in the Nursing Standard, which shows I still do a bit of homework. And I thought, now what else could I call it other than intentional rounding? I don't really like that term very much. It doesn't really mean too much, and I envisaged that it might be, for instance, a team of nurses going around to actually problem solve around the ward with the patients, and I thought, yeah, that's what we used to do. It wasn't quite like that, was it? And I think that probably it could get a little mechanistic, but anyway, you're going to evaluate it, so that'll be fine. But I think that there are three characteristics that excellent nurse researchers like Ruth really require. And the first is, charming persuasiveness. If you can just imagine how she would have had to really encourage the staff to be involved, not only involved, but involved for a long, long time, not only in sustaining their behaviour or even sometimes changing their behaviour. And the persuasion really also was in organising care. Nurses do organise care, and perhaps in changing the way that they were organising care and actually sustaining that, I think that really meant that somebody, the researcher, was there all the time encouraging that. So that's number one. The second characteristic to me, actually, is the tenacity. It's so important that you carry on over several years. It can get jolly repetitive, can't it? All that data from the staff, having to collect it over several years is really tough. And, I remember celebrating, was it 80 patients on the NDU? And anyway, we got the sample, after about 2.5 years of data collection. So tenacity is absolutely vital. The last feature, of course, is intellectual strength. There's absolutely no doubt about it that one has to be so clever to conceptualise, operationalise, assess, measure, collate, compute, and hopefully sometimes statistically, you can actually also calculate whether the effectiveness is there. So I'm sure that many of you will agree with me that it's a rare combination of those three features, and Ruth has demonstrated this so well. The presentation of this is so important. And I think probably it is quite rare, but I'm sure there are lots of people in the audience, or anyway a few, who will perhaps aspire to getting a chair at King's, because we all enjoy the inaugurals so much. I especially do. But so thank you, Ruth, and well done on your career and on your presentation today. Thank you very much.
Thank you very much. And thank you also to Jenny and Ruth, and I'm going to ask you to give them a clap once more for their making our evening.